While waiting for the slides to come on, so my name's Tom. I work at the strategy unit. I'm a senior data scientist there, and for the last probably 18 months or so, I've been working on this large project where we're trying to build a demand model as part of the new hospital program. Initially, that was with the Department of Health and Social Care, but of late, that's been taken over by people at NHS England. We're getting the thumbs up. Slides, hooray. So, this is a very big project, and there's an awful lot of people involved in this. We're in the strategy unit. We've got Peter, Chris, Stephen, and Jake on the top row. Mike, Andrew, Paul, and myself on the bottom. And there's also Azare and Stacey, but they don't have nice pictures on the website, so sorry you've been left off. We've also had people from our sister team, the Health Economics unit, working on this. So there's been Rukia and Andy Olalski. And I think the Transformation unit, which is one of our sister organisations, is going to be joining us soon on this whirlwind tour of demand modelling. But kind of for some context, I came across this quote very early on in my career in the NHS. It's kind of always stuck with me. It gives a good sense of the importance that hospitals play in our lives. And it should lead us to the question of, as we're planning these new hospitals, we must be making sure that they are appropriate for the needs. Now, I'm sure we can think of many examples in the past where a new hospital has opened, and almost from day one, it's insufficient for capacity. There's been old buildings that have been kept open when they was expected to be closed. And this is not a unique problem to healthcare. So a recent example of poor planning is this school that opened in Glasgow. So they designed it to meet the capacity of the existing school. There was about 400 pupils at the time. So they built it with a capacity of 548. And then afterwards, the council admitted that they had a planning error, forgetting that there was a new housing estate being built. And over the next decade, they expected to need double the amount of seats in the school. So we know that planning is a hard problem. Now, I'm going to try and cover some of the points that Stephen made in his talk at NHSR last year, and I'm going to do a much poorer job than Stephen did of these. So I would urge you to just go ahead and find this video afterwards. It's a great talk. But as part of this project, colleagues within the strategy unit and across the HSC did reviews of existing models that people have built for kind of demands of future hospitals. And they found that there was lots of different models. Surprise, surprise. Some of these have been built by trusts and their analysts in the teams, but an awful lot have been built by external consultancies, your typical kind of management consultancies that come in and give a black box model, don't explain how they've gone to any of their conclusions and present their findings as if it's the truth. And what we found was there was an awful lot of repetition and duplication between these models. But there were sufficient differences between these models that when you're trying to compare the results, it was impossible to tell whether the differences that you were seeing in the results were due to assumptions or they were due to different methodologies that were used. The methodological progress has been slow. We've not learned much over the last 20 or 30 years in these planning tools that have been built because they've been built independently. And that's given us no base to build from as we try to develop these types of models. There's a lot of common issues that are found in the typical modelling process as well, including the models that the strategy unit had been involved in the past. Most of them give point estimates. So they say, in the future, there's going to be exactly 120,000 admissions. No attempt to try and estimate any of the uncertainty around that future capacity. And a lot of the models have very early aggregation of the inputs. that leads to less kind of differentiation that we can make in the outputs. There's poor coverage of some of the changes that we're expecting to see in kind of future healthcare demand. So most of the models try to handle things like your demographic change profiles and some kind of activity mitigations that might be taking place, but few try to handle adjustments to health status. So we're expecting people to generally be healthier in the future often. Most of these models don't take account for that. There's also a lot of the assumptions that go into these typically black box consultancy models are very opaque. We can't audit any of those assumptions that go into the models. And then many of the models try to conflate demand forecasting with the affordability. So specifically, we're going to try and answer this question. How much and what types of activity might hospital need to accommodate in the future? So with that in mind, we're going to try to build a model that's going to be open source, though it's not yet available to be open source. That's perhaps a conversation we can have later. And it's going to be built on well-known data sets. So we've built it on the hospital episode statistics data. It should be able to ingest SUS data. It's a very English-centric point of view, but I expect that Scotland, Wales, any other country in the world probably has data that could be wrangled into that same kind of format. Currently, it's built to handle inpatient, outpatient, and A&E arrivals, though we expect it should be quite extensible and adaptable to different types of data. And it's covering all of the change factors that we think will be important to model in how demand will change in the future. It's also built to be randomized in the way that it's running each kind of model iteration, so it's doing a Monte Carlo simulation to try to handle that uncertainty, to give us not just a single point estimate of the future demand, but a kind of confidence interval to help people get a better understanding of what demand they might be having to accommodate. So this is an overall project structure. Whether the diagram is particularly blurry, we start at the top. We've got kind of a data extraction pipeline that flows data into some different kind of buckets that we're storing data in. So we've got really sensitive model data, less sensitive data that's kind of contextual information for an input application, which is kind of on the right-hand side there. That's allowing the user to set parameters into the model itself. I'll cover the model mostly for the rest of the talk. That model will generate some data and store it into a results bucket. And we have an output application to kind of show the results. There's a lot of different technologies involved in this, so a lot of use of R and a lot of use of the Shiny web framework. We're using a lot of SQL for the data extraction and manipulation. We're using Python for the model engine, and Docker to kind of run that. Heavily using Azure infrastructure, so we're using a lot of virtual machines, Azure Container Registry, Azure Container Instances, and storage accounts, and everything's stored on GitHub. You could say it's one of those using the right tool for the job, but I think it's often been used the tool that I'm most comfortable with to do the job. So I'm going to kind of go over the model mostly. I'll show some of the other applications at the end, but it's going to be a little bit rushed through those. That's perhaps a talk for a different day. So the model itself starts with a baseline year of data. So that's going to be a provider's HES data. It could be a different cut of that data if we want to. At the moment, it's just built to look at an entire year's worth of that data. So we have the row level data, and we're going to run that data for a series of steps to adjust the data. What that step will do is it's going to create a factor that says, on average, how likely do we think that row would be expected to appear in the future? And we've got lots of different steps that we're running. Those each create their own factors, and we multiply all those factors together. We sample from a Poisson distribution, so a Poisson distribution is just a nice way of getting a kind of integer value that says, in the future, we'll have one patient, type of this patient coming in, 2 of these patients, 0 of these patients. We never end up with 1.3 of those patients. Once we've done that Poisson sampling, we take that value and resample the row that many times. A kind of final step, we apply some efficiencies to those rows of data. So say the patient was listed as having a 5-day length of stay, we might say that there's 75% reduction on that, so maybe randomly it picks 3 days for length of stay. So again, it's a bit blurry, sorry. What we have at the top, the baseline activity of data, that's flowing through all these row resampling steps, and then it gives us our estimate of the future activity. We've got a number of different buckets that we're showing here. So on the left, we've got these population changes. So that's things that we're expecting to see with the changes to the population structure in the future. We base that off ONS data, such as the estimation of the population over the years. That gives us a kind of change to the age structure. And then we also have this population health status adjustment. So looking at life expectancy tables and estimations of how people might be healthier in the future. That allows us to kind of oversample or undersample some of the rows of data. We have some series of steps of what we're calling demand supply imbalances. So we know that hospitals are struggling to meet capacity at the moment. What we don't want is to take those struggles that we're seeing at the moment in the baseline data and push them through into the future capacity. We'd hope that the future builds would better suit the needs and demands, and that's what those steps are adjusting for. We have need supply imbalances, so this is handling gaps in care, inequalities and inequities in care, issues with thresholds, imbalances, so where we have things like IVF. At the moment, there's thresholds that say only so many times you can go through that process and you've got to be a certain age. Maybe we'd adjust those in the future to offer that service to more people. And then we have the non-demographic adjustments, so things like improvements to medical technologies in the future. The final step is this kind of activity mitigators. So these are strategies that organisations might employ to reduce activity in the future. So, for example, you might think that you could do a better job of handling readmissions, so we can adjust for those in the future. We also have steps for type conversions, so we might think that we can more efficiently treat people in the future by offering telephone appointments rather than face-to-face outpatient consultant visits. So we have a step for kind of changing rows of data to act like those. And then these steps for efficiency, so making it so length of stay is reduced, or other kind of things that we might expect in the future to be delivered more efficiently. So that's a single model run. The data starts off through that baseline activity. We resample the rows, adjust the kind of types of data in that, and that gives us future estimations of activity. Just those colours there, so some of those steps at the moment are implemented. Those are the yellow ones. The ones that aren't yet implemented are coloured in blue, so we haven't yet implemented all the need supply imbalances. We do have some for the non-demographic adjustment at the moment, but we know that it's a stopgap measure, so we're just kind of labelling that as not yet done. So as I mentioned earlier, we do this as a Monte Carlo simulation. So we run the model 256 times, or maybe 1,000 times. And each time we're going to slightly vary the input parameters that the user gives us. So if the user says, we expect maybe that we can reduce readmissions by 75%, maybe sometimes we'll say that's actually 70%, sometimes we'll say it's 80%. We'll run the model each time with the same baseline data with those slightly varied parameters. At the end of each model run, we aggregate the results. And those aggregated results are then combined at the end of all of the model runs into a single file. We do this because if we end up trying to do all these model simulations and end up with row-level results for all of the kind of 250 or 1,000 model runs, we quickly realise that you run out of RAM on most computers. So by doing this approach, kind of inspired by Google's MapReduce paper and the split apply combined paper by Hadley Wickham, this is something that should run on most kind of NHS-IT laptops. In terms of the parameters that we ask the user to provide, what we ask for is confidence intervals. So we'd say to the user, we have something around, let's say, smoking cessation and how we might reduce admissions for those kind of patients in the future. And instead of just saying we want a point estimate of what you think you'll reduce that kind of activity by, we ask them to provide 90% confidence interval. What we then do is we convert those confidence intervals into distributions, so a normal distribution. And during each model run, we then resample values from those distributions for each model parameter. Those parameters will represent the average amount of times that we want to sample a row of that data from the baseline for that particular part of the model. So as a little kind of diagram, the user might say we expect a 25% reduction to a 25% increase for the type of activity. So that's the kind of grey area. The black line is then the derived confidence interval, and the yellow points are points that we're sampling from that distribution set for each model run. The particular values we need to kind of cut off at 0. You can't say we're going to sample a row -1 times. So the distribution's kind of hard cut off at 1. And for some of the parameters that are representing things that are always going to be a reduction, we have a hard cut off at 1. So that's saying we want to sample the row exactly as many times as it appeared in the baseline. So as a kind of toy example of how this model runs, imagine that we have some data that looks like this. So pretend this is the inpatient data. We've got different columns of data in this, and each of the rows of data is represented exactly once. So that's the kind of F column at the end. That's saying this row is appearing once. Now, one of the steps might be to sample based on age and sex. And we can say here that that first row, the kind of middle table, 50-year-old males, we're expecting in the future that they would appear 0.9 times, so a 10% reduction for that type of individual. We then join the left and the right table, left and middle table, to give us the kind of right-hand side. And we multiply the two F columns from the left and the middle table. And that's now saying, for that particular row, we now expect it to appear 0.9 times, 0.9 times, or 1.1 times. We keep repeating for all of those different steps that I showed in the diagram earlier. We'll have different columns each time. So in this case, we have a specialty column, let's say. And we do the same process of doing a join, multiplying the two F columns together. What you might notice if you kind of squint is the middle table doesn't have a row for specialty 120, whereas row 3 and 6 have that 120 specialty. In those cases, we just pick a value of 1, so when we multiply the factors together, the previous value remains unchanged. Once we've done all of those steps, we end up with the table on the left, and we generate the column N using the Poisson distribution, resampling with that column F as the lambda parameter, so that's the average rate that we want to sample from the lambda Poisson distribution. And that's saying then that we want row 1 to appear once, we want row 2 to appear no times, we want row 3 to appear twice. And we use that to create the table on the right. So you can see the first row appears once, second row doesn't appear, row 3 appears twice. We then apply the steps for doing the efficiencies. So in this case, we do just the length of stay reduction, and that's showing here that we're going to pick a random value g. So doing a similar thing of creating tables that we join to create these factors. And in this case, we use a binomial distribution. So that allows us to sample a random integer value between 0 and that length of stay column. So we're never increasing the length of stay in the future. We're always reducing it or keeping it exactly the same. So that's a run through of the model for inpatients. Outpatients and A&E is very similar, except we don't have like length of stay columns. The model's built in Python, and it can be run on any machine that you can install Python on. So if your IT lets you, you should be able to run this. It's using various kind of standard Python packages like NumPy and Pandas. So that just allows us to do numerical calculations, and it allows us to do the data frame manipulations. We're using Parquet format for efficiency. So Parquet is kind of like CSV on steroids, I like to think of it. It's a very efficient and fast way of storing data and processing it. The final data is stored as a JSON file. It's a bit of a complicated format for some of the analysis that you might want to do afterwards, but we've got some standard R scripts to take that and turn it into lots of tables. It is possible to output the full row-level results from the model if needed. It just needs more computational power than you typically have, so you might need to use things like Spark or other high-performance compute solutions. The code's built in a very modular approach. So what we have is each of the types of activity, inpatients, outpatients, and A&E, has its own kind of model code, a class of data. And those are derived from a generalized model class. So the general model class will have a lot of the code, so all of the demographic stuff is shared between all of the individual types of data, so individual model codes. But then when we've got things like waiting list adjustments, they're handled slightly differently for inpatients, slightly differently for outpatients, and A&E it does nothing at all. So in those cases, we kind of split the code into its own class. That should make it quite easy, hopefully, to adjust this model for different types of activity in the future, maybe mental health or community activity. We deploy the model in Docker containers. Docker is a great technology for taking your code and getting it to run in other environments. You kind of package both your code as well as all of the dependencies to run that code. So if you've ever heard someone say, it ran on my computer, I don't know why it's not running on yours. Docker is meant to be the solution for that. It's using something called Azure Container Instances to run those containers. So when we actually want to run the model, it starts up this new container instance for us. It runs the model code. Once the model's finished, it saves the results and it destroys the container. This is a really neat way of getting your code to run in this kind of way because the computation costs on this, it takes about 2 to 5 minutes to run the model. I think it costs about 2p for each model run. Compare that to booting up a virtual machine, just leaving it running 24/7. Yeah, it comes at a significant cost saving for us. Now, in the remaining time, I just want to touch on some of the other parts of this. So we've got the data extraction pipelines. These are built on RAP principles. So we're using R and the targets package. Targets is an absolutely amazing package in R. If you're not aware of it, you should go away and look at it. It allows you to kind of codify all of your steps as you're building your data extraction and data manipulation. To say, I've got some code that extracts my data from the database, and then I've got some code to generate the plots. The code to generate the plots needs the code to run before it for extracting the data. So if you've ever run something and you've got like script 1, 2, 3, 4, 5, targets is the solution to that. It stops this kind of stupid mistake of forgetting to run your scripts in the right order. The input parameters, this definitely could do with an hour-long talk in and of itself, but there's a shiny web application that the user can come in and pick which organization they want to run the model for, select the model year, and what baseline year they want to run the data for. We use the NHS Peer Finder tool to show similar organizations to the one that you've selected. So as you go through some of the other pages and set the parameters, in this case, this is setting on the activity mitigators, and it's the alcohol partially attributed mitigator that we've got built into this. So this is looking at all the patients that come in with conditions that may be caused by alcohol. It's then given us some kind of context of the historical trends of admissions for your organisation, how you compare to peers, and it allows you to kind of set where they might be reducing that activity to in the future. That also has the ability on another page to send that model off to run on a container instance environment, making it quite easy for users to run the model. The output SAP then has loads and loads of different kind of views and cuts of the data. In this case, I'm showing a chart that's the outpatients follow-up attendances. The black line on the left is showing the baseline value, how much activity there was in the baseline year. And that dotted line is kind of the central estimate from all of the model runs. Each of those individual dots on the bottom is one individual model run. And it's a bit too blurry on this screen to see, but those are coloured based on the different population projections that ONS provides. So typically what we're seeing on the far right, these are the high migration and high population growth models that ONS projecting from. And on the left-hand side, it's the lower estimates from the population growths. We also can kind of break this down as well, so you're looking at the effects of each of the individual steps. So you can see the demographic adjustment is the second line down on that. Then the top line is the baseline value. And in the black lines, there are things that are reducing activity. That's pretty much it for my time. If we've got any time for questions, probably like a few seconds. Happy to take them. Otherwise, contact details are up on the screen. Thank you.
Does anyone have any questions for Tom before we show our appreciation? Oh, there's one. And he's close. Thank you.
I also love targets. Do you think that it might be useful for capacity and demand and capacity planning for existing hospitals and existing systems?
Yes, the hope is that we'll open source this at some point in the future, and it could be utilised for other needs. A lot of the steps are very generic. Things like the population growth is just looking at ratios between the future year of the ONS are projecting for population and your baseline year. So it should be adaptable to most of the types of demand planning. Capacity conversions would be steps that you'd apply on top of the results of the data. So we do have some of the capacity conversions built in, so try and convert the activity to bed occupancy. I haven't shown that in this, but yeah, hopefully it'll be useful for those needs.
I think that's a yes. Any more questions?
I like it's all the people that I actually know asking me questions. You're making me feel even more nervous.
Sorry, Tom, but thank you. It looked a really interesting piece of work. I was just wondering why you had basically an iterative approach to the sampling, and my particular concern that you're going to tell me why I'm being an idiot is that if you have some odd data in there because it's iterative and not kind of all at once, you'd overrepresent one group. So we found like a male event in a maternity, you're going to hit 50% of your population. So yeah, why am I being an idiot?
Yeah, so male in maternity, great example. Hopefully we'd have data cleansing steps that we apply beforehand to pick up oddities like that. There is a step that was kind of ignored in this, but there's an ability to adjust the baseline data. So for instance, if you're using the 2019 data, we've got a step to adjust for COVID at the end of the year for March. So if you had some oddities that you knew about in your data, you should be able to adjust for those from the baseline.
Okay, thank you very much, Tom.